am Andrea Magnacavallo, Director of Emergency Department of Piacenza.
I'm Dr. Stefano Zito, and I'm working in Cesena, that is a trauma center hospital in the north of Italy.
My name is Trent Shea. I am the ultrasound director for Mount Sinai, St. Luke's, and West.
My name is Emanuele Pivetta. I'm a staff physician at the Division of Emergency Medicine in the High Dependency Unit in the western of Italy.
Why lung ultrasound? For me, lung ultrasound is quick, is effective, and is protective. It is more than safe, it's protective. You can do a rapid scan just in 2 or 3 minutes maximum.
The beauty of lung ultrasound to identify coronavirus is it's easily repeatable. There are definite findings that you can see in viral pneumonias. It's far better at looking for the peripheral ground glass opacities when compared to X-ray. And because it's repeatable, you can use it to track disease and see how patients are improving or seeing if patients are worsening based on your treatments. Because I'm honestly replacing most of my stethoscopes with ultrasounds.
In my emergency department, I don't have my stethoscope. I don't use it. Probe.
Ultrasound helps me in one of 3 cases. The first case is you are in some kind of triage area, like a tent type area or somewhere outside your emergency department. And your question is, okay, I don't have an X-ray here in this tent, or I want some other way of figuring out if my patient is very sick. You can use your ultrasound to look for signs of a viral pneumonia, and you don't see any signs of a viral pneumonia, that patient you could potentially just immediately discharge. The second use it is for people that I'm on the fence for. That would be either young patients who have like a borderline O2 sat of like 92, 93%, or for old patients that have a normal O2 sat but have like other like comorbidities, like a 70-year-old with hypertension, hyperlipidemia. Those patients I use ultrasound because if I see diffuse findings on ultrasound, that suggests to me more that maybe they should stay in the hospital. But if I don't see very many diffuse findings, I usually keep them. I usually tell them to go home and to monitor their symptoms. And the last way I usually do in terms of finding ultrasound is patients that have other comorbidities, like patients that come in with CHF, COPD, and also are short of breath and maybe have a fever. Those patients are very difficult to figure out what's necessarily causing their shortness of breath. The fever usually points towards pneumonia, but the CHF and COPD on top make it hard to figure out exactly what process is going on. And each of those patterns presents differently on your ultrasound. And so that's the other area where I'm using the ultrasound a lot.
Ecco, l'ecografia io ritengo che sia un esame molto molto sensibile. E quindi ha un enorme valore come screening. Quindi ogni qualvolta si sospetta una polmonite, se non ci sono alcuni segni ecografici la si può escludere con certezza.
Lung ultrasound is the perfect tool for me, especially for its ruling out power, for negative predictive power. If it is negative, for me, I have a higher value, because if it's negative, it's an important piece of my puzzle, mixed with clinical sign, with comorbidity, with age, with all the other features that we must take in consideration. A negative lung ultrasound is a radiological data that allow me to take in consideration the dismission of the patient without performing a CT scan, and also without performing just X-rays. After that, lung ultrasounds recognize an important role of monitoring my patient. Perform a lung ultrasound and I found a lung ultrasound that it's negative lung ultrasound, or just, for example, a focal localized B line that is a interstitial pathway, just in, for example, in the in the basal zone in the right lung, for example. I discharge a patient, I sign what I found, and so I I address to the family doctors these my findings. And if the family doctors can perform scans during days, can see the evolution.
In quest'ultimo mese non c'è paziente con polmonite di cui non ci sia un'evidenza ecografica.
So this is a patient who was 25 years old, who I actually didn't think too much of. They had stable vitals. They had just from hearing the story, I probably wouldn't have worked it up, but I reached for my ultrasound and I'm looking at both areas. And I'm saying, okay, well, this guy has an effusion in both posterior axillary regions. So we ended up actually doing a workup on this guy, and he ended up getting admitted to the hospital just because during our workup, he was essentially just not breathing very well. And so this is one of the cases where I was like, okay, like a 25-year-old guy, there's no way I'm going to without the ultrasound, there's no way I would keep this guy. But here you can clearly see that there's findings on one side, on the right side, and you can see that there's findings here on the left as well. It's really not that tricky to pick up. Like the findings that you see, like you just saw on the ultrasound images I saw, they really are not subtle. Like if they're abnormalities, you will see abnormalities.
If you just would like to see what happened in the patient lungs, no, it's 2 minutes, probably less.
For me, like it's almost like a cheat code. It's basically telling me exactly what the cause of shock is or what the cause of shortness of breath is. For this particular case, when you're doing ultrasounds of the lung to look for signs of viral pneumonia, you're not looking for everything. You are not a sonographer. You're not a radiologist. You're not looking for everything that could be wrong. You're looking to answer a particular question. You're looking to see, okay, does my patient have signs of viral pneumonia? Yes or no?
Nella nostra esperienza, uno degli errori più grandi che abbiamo fatto in Italia e per cui in qualche modo abbiamo alimentato nelle fasi iniziali il protrarsi dell'epidemia, ma col senno di poi, se avessimo fatto l'eco a quei pazienti, avremmo capito che quei pazienti avevano polmonite. Loro sapranno bene, la polmonite è nella infezione Covid, è una complicanza che interviene in 8ª, 10ª giornata e non si presenta sempre in modo grave all'esordio. Quindi un paziente che viene in pronto soccorso, soprattutto in un momento non epidemico, con una lieve insufficienza respiratoria, spesso non fa la TAC e facendo la radiografia, solo la radiografia del torace, si corre il rischio di non comprendere che quel paziente ha una polmonite interstiziale. In questo senso l'ecografia è superiore e ti permette di sospettarla. In Italia nella fase di grande epidemia è difficile fare i tamponi e comunque l'esito del tampone ci vogliono anche 2 giorni. Noi in tempo reale con un'ecografia positiva mamo nel reparto Covid dedicato il paziente sapendo già che quel tampone sarebbe stato positivo. A fronte di un'ecografia positiva, se il tampone era negativo, lo ripetevamo perché era un falso negativo e l'ecografia era più attendibile del tampone stesso.
One of the lessons from the COVID is that we need to keep going and keep integrating our physical exam with the point of care ultrasound, in this case with the lung ultrasound.